really have the pleasure now to introduce my esteemed colleagues who are in the panel today, and I'm going to do this by listing them in alphabetical order. I hope you will accept this. So I'm going to start from Dr. Veronica Bruno. I'm going to ask you to just to stand up for a moment. Veronica is a movement disorders neurologist and specialist at the movement disorders clinic here, and she's also an assistant professor at the University of Calgary, and she's a clinician investigator, and her research focuses on improving quality of life in advanced Parkinson's disease. Dr. Vikram Karnik, he is a movement disorders specialist and neurologist. He's a clinical assistant professor, and he's also the site chief for clinical neurosciences at South Health Campus, as well as the director of the neurology residency program at the University of Calgary. So certainly a very busy body. Thank you. Dr. Scott Ryan. Dr. Scott Ryan has joined our program this year, and we are really lucky to have him. And he's an associate professor here in Calgary. He is a researcher, and a scientist, and his research uses human stem cell technology to build 3D models of the brain to study the origin of Parkinson's and develop therapies that preserve brain function and undo the damage caused to brain cells before it becomes irreversible. And last but not least, Dr. Justina Sarna. She is a movement disorders neurologist who works here in Calgary and is also a clinical associate professor at our university. And she has extensive clinical experience in managing Parkinson's disease across all stages. She has in particular gained recently subspecialized expertise in continuous infusion therapies using levodopa, carbidopa, both the intestinal gel that has been around for a while, the duodopa pump, as well as she was the trialist here in Calgary for the subcutaneous fos-levodopa, fos-carbidopa pump that I hope we'll have the chance to discuss today as well. Thank you very much, and I will now sit down. My role is here to, as I said, to moderate the discussion and to get it started. And I would like to start from, well, first of all, giving you a little bit of how we would like to operate today. I think we will start by talking a bit more in general about Parkinson's and discuss a bit more about Parkinson's mechanisms and diagnosis, and then we'll move to treatment. So that's the kind of sequence that we will follow. And my role is also be to stop the discussion at some point and ask the audience if there are specific questions around the theme that we will be discussing in that moment. We'll start by, so if you have already some questions about diagnosis and mechanisms, just keep it ready to go for when we'll be taking it. So one of the striking points about Parkinson's is that its prevalence, as I mentioned, is rising and is rising a bit unpredictably and we were not unexpectedly to some extent. And it is rising beyond the rise of the average age of the population. And we know that Parkinson's is genetic, and has a genetic component, but it's also an extra genetic component that may come from the environment, for example. And it is quite obvious to start thinking what is there in the environment that is partially contributing to this rise in prevalence of Parkinson's. And so I'd like to start exactly from this point. What are the environmental factors that we should be interested in research, but also in the general information that we have about Parkinson's that could be contributing to the mechanisms that lead to the development of Parkinson's? And maybe we'll start from Scott. Give us a little comment on this.
Sure. Can everyone hear me? Good. Yeah. So really, I think it has to do with an interaction of environment and genetics, and you may not, have a a specific mutation that is causing the disruption, but you may be susceptible to certain environmental factors that are there that are making things a little bit worse. And I like to think of it as there is a threshold, and if some people are pushed beyond this threshold of stress, then it will trigger something that is now a behavioral phenotype. And so there seems to be strong associations with agrochemical exposure, pesticides, and they can increase risk by almost twice in terms of the propensity that disease will come about. There's also associations with pollution and a general association with industrialization. And how I think it manifests is that there is a change in how the brain responds to these stress mechanisms. And if you're exposed to certain environmental chemicals or certain pollutants or certain stressors, that in some people you may be pushed beyond what the system can tolerate. And it's not going to be the same in everyone. So that's why we say, it's about a doubling in risk. And it used to be that we thought it was quite narrow with respect to what agrochemicals this might be. And now it's seeming to be more and more being added to that list of potential stress-inducing or at-risk molecules. So I think it's more of a generalized response to stress on the system than it is one chemical. If I was exposed to this caused a problem. But I do think there are also positive modifiers. And so this has a lot to do with diet and exercise. And so we know that Mediterranean diet, if you eat a diet that it's in the upper quartile for omega-3/6 fatty acids, that seems to reduce the risk. So I do think there is a lifestyle component as well, and that things can be done that potentially bring that risk back down a little bit. But I think the increase in industrialization and exposure to pollutants and chemicals in the environment is one driving factor.
Thank you, Scott. That's very important, and obviously, thinking about these different factors, we're thinking about mechanisms that are happening in our brain and our body that can lead to the gradual development of Parkinson's, and obviously, understanding these mechanisms is important because we need to identify them as early as possible and be able to apply novel interventions that are targeting these mechanisms as early as possible, which means that and a lot of the research, basic and clinical, that has happened in the past few years is really focused a lot on how can we best identify a situation where we are very early in the condition, even before the moment in which normally a person would go to a doctor with symptoms that are suggestive of Parkinson's. And so this brings me to a related theme, which is diagnosis and early diagnosis, and also a distinction between what is normal aging and what is Parkinson's aging. So I guess probably we'll start from that and start by teasing out what is that clinicians do see different between let's say a physiological process of aging and a manifestation of Parkinson's. Vic, do you want to?
Sure. Yeah, I can take that. I think this is a good place to start because it's quite fundamental to kind of what we're doing here. And Dr. Martino already mentioned, some of the motor and non-motor symptoms of Parkinson's disease, but maybe I'll kind of walk the audience through that a little bit. So when we talk about motor symptoms, we think about tremor, stiffness or rigidity, and then slowness of movement or bradykinesia. And if we just look at those symptoms in isolation, and we look at a population of people above the age of 75 or 80, we may see some of those symptoms in that group, whether they have Parkinson's disease or not. So then we need to hone in on those symptoms a little bit closer. And so we look for things like, are the symptoms asymmetric? Are they progressing at a certain rate? Do the symptoms respond to levodopa? Is there eventually going to be some dyskinesias associated with that? Is there dystonia or abnormal posturing that comes on with those motor symptoms? And then we take those motor symptoms and combine them with non-motor symptoms, right? So things like REM sleep behavior disorder or acting out dreams in sleep. Autonomic dysfunction was mentioned, so constipation, urinary symptoms, lightheadedness, perhaps some cognitive symptoms, perhaps some mood-related symptoms. And when we piece all of those symptoms together and look for progression of those symptoms, we then say perhaps someone meets a clinical diagnosis of Parkinson's disease rather than the normal process of aging. Of course, as Dr. Martino was alluding to, there are new techniques that are coming out that are, stronger biomarkers than a clinical examination, but ultimately looking at those motor and non-motor symptoms of the disease, and then seeing many patients with those symptoms and having that experience leads to the diagnosis.
Yeah, that's a beautiful overview of the complexity of the picture, but also how many hints we get from our clinical observation, and how important it is to receive a confirmation from an expert sooner than later, and when we are suspecting this. Obviously, I was alluding to early diagnosis, and I was alluding to ways that we have to also understand if a person with a presumed diagnosis of Parkinson's has a particular type or subtype of Parkinson's. This is really important because ultimately interventions will have to be as much as possible personalized, but we are, and just talking about Parkinson's means just talking about a broad spectrum. So I just wanted to ask Dr. Bruno, what is your opinion about how good we are becoming in, if you allow me the term subtyping people patients who have Parkinson's disease, and how that might help developing more personal or accelerate personalization of treatment.
Well, just to start, thank you. Hello. Just to start, this is a very important question, and I think it's important also from your perspective because, we mention all these symptoms, motor, non-motor, but you may go home and say, okay, I don't have this or that. Do I still have Parkinson's? Or moreover, sometimes you have those, but you end up having a different diagnosis, maybe one of the atypical Parkinsonian syndromes. So clearly what we do in the clinic is very important, and unfortunately is still the best way to diagnose Parkinson's we have, but it's not perfect. So that's why we, sometimes tell you, well, we need to wait a little bit to put a final name to these. We need to see how you respond to the treatment. We need to see how symptoms evolve. And for some people, symptoms evolve in one way, and for other people, they evolve in a completely different way. With this, what I'm trying to bring is this concept of subtypes. So from a clinical perspective, you will meet people with Parkinson's that only have a very severe tremor. And maybe they don't even notice that there is some stiffness or slowness, and the tremor may be the main predominant symptom for many years. For other groups of people living with Parkinson's, the problem is only the stiffness and the slowness without tremors. And those are a bit trickier because everybody knows about Parkinson's and tremor, but what if I don't have tremor? And we call that an akinetic or rigid form of Parkinson's. Most of patients during the course of the disease will have a mix of a little bit of tremor with a little bit of stiffness, a little bit of slowness. And then as the disease progresses, other things that may arise, like a little bit of balance problems or speech changes. In terms of the non-motor symptoms, we also know that the picture can be very different for many people. And it's not correlated with tremor or non-tremor. For instance, some people have depression or anxiety or constipation for 10, 20 years before developing the Parkinson's motor symptoms, while other people never notice a non-motor aspect. Some people start acting dreams very actively early before starting to have the motor symptoms. Some people only start having those active dreams 10 years after the diagnosis. So there's no strict line, and that's why we're trying to tune up our observations and add different methods to try to help clarify this. Is one Parkinson's, or there are a lot of Parkinson's diseases? The consensus right now is that even all these different types look a little bit different. They share very common core features. The changes that we see in the brains are similar. The dopaminergic deficit is the same. And the pathology, when we look at the brains, is very, very similar with some minimal exceptions. The genetic forms also gave us a lot of information, because we know, the basic researchers know that most of the genes that are affected in Parkinson's affect some specific types of the neurons. And that gives us more information about how all this comes together. So we still depend on clinical aspects for diagnosis, but we're trying to move away from that. And I don't know if you want me to answer the next related to this one, and how we are incorporating different things to diagnosis.
Yeah, I mean, I was going to get to that, but maybe if we can just take a little pause from that angle, and since you mentioned depression and some mental health features, there's one question that we have received that is obviously related to this, and it's quite straightforward, and asking whether people with Parkinson's have a higher tendency to develop depression, and whether there's a difference between the depression that we see in general population, so to speak, and there's a specific type of depression that needs to be treated specifically in the context of Parkinson's.
Yeah, that's a great question. Thank you for whoever brought it, because this is usually a very not really explore aspect. And when you come to the doctor and they usually ask you, about your medications and about the tremor and the stiffness, non-motor aspects sometimes are not even part of the visit. Or, you at home may think, well, for sure I'm depressed because I have this diagnosis and a lot of uncertainty, so it's normal to be depressed. The truth is that that's not the case. So depression is one of the non-motor aspects of Parkinson's disease, is one of the symptoms of Parkinson's disease as common as others. And there is some discussion around it, but it seems to be a little bit different than depression in general population. So sometimes people have feeling depressed for a long time, then develop tremors or stiffness, and then they start treatment with a dopaminergic agent, and the depression goes away. So while we usually speak about SSRIs and serotonin being a very important substance for depression in the general population, in Parkinson's there is a mix of that serotonin with the dopamine that we know is deficient. And sometimes our strategies are different, like just start the regular antidepressants, even if they can still help. So yes, it's more common in Parkinson's than in general population. Yes, it's part of the disease itself. And yes, you need to chat with your doctor about it, because it may have a different approach or different alternatives for management. And what is more interesting that is coming out more and more in studies now is that if we treat depression, all the rest of the aspects become much better. So improving depression has a correlation with better outcomes in terms of motor symptoms. So people that do not have depression feel less stiff, less slow, and less shaky. So this is a very important aspect, and I think it's very important to clarify. The same way anxiety is part of it, and other symptoms. Sometimes we confuse a little bit apathy with depression, and that's something also interesting to discuss with your team, because apathy is also part of Parkinson's, and is this kind of, lack of motivation. I prefer to stay at home. I used to love going out. Now I want to stay, and I don't want to see my friends. apathy has a different mechanisms, even if they are very closely related. And apathy is more difficult to treat, but not impossible. There are a lot of strategies that we can use to make it better. So yeah, it's different than in general population, but it's a very important aspect of the disease.
Thank you. Okay, before we open the question to the audience about the diagnosis and mechanism team, I just wanted to spend a few words about a very important topic, which is a word that you must have, if you have read about Parkinson's, you have heard about the alpha-synuclein. So this is this protein that aggregates in an abnormal fashion in the brain, and which is tightly connected to the development of Parkinson's and the loss of brain cells throughout the course of the condition. It's also a target for the new interventions that are being designed to try and change the progression of the condition. But if you read if you go on internet, you get a lot of mixed messages about alpha-synuclein. So on one hand, it's considered the source of all the problems in Parkinson's disease, and that we should target its abnormal aggregation. And then you also read opinions saying, "Oh, the problem is not that it's aggregating abnormally. The problem is that we are losing the normal version of this protein through this aggregation, and that's the main issue. A lack of alpha-synuclein normally functioning as opposed to an excess of abnormally aggregating protein." I know it's a little bit they sound a little bit tough concept, but actually when we bring them on the two plates of a scale, actually it seems pretty good material for debate. So we are fortunate because here in Calgary we have an alpha-synuclein scientist, and who is Scott Ryan. And I really also an important thing is that we also a great novelty of this year has been the development of a new test to assess in our spinal fluid, not in our blood yet, the aggregation of alpha-synuclein in a way that it's that would help diagnosing Parkinson's. And so I just wanted for Scott to comment on where he sees the field going, and how to navigate through this complex messaging that we can find on the internet about alpha-synuclein.
So I think one way to think about it is as a continuum. So as you described, you have a protein that's important for the dopamine producing cells in the brain, and it's important for dopamine signaling. And so early on, you'll be losing function of that protein at that site. And so you might have some early deficits in dopamine signaling that result from that. And then as that is lost from that part of the brain, it's starting to aggregate and now creating a secondary problem. And so I think that's why you're reading about two different things. And so now you're making aggregates, and those aggregates in and of themselves can be toxic. And so now you are dealing with two stresses. You have the stress that you have to compensate for the loss of the normal protein, and you have the stress that you've now gained this toxic protein, and what are you going to do about it? And the cell's way of dealing with it is to just say, okay, give me all this stuff. I'm going to package it into a big clump, and that's what we come to know as Lewy bodies that accumulate in this disease. And that's really probably a third element, that the Lewy body might actually be an attempt to protect. So you have two insults, and now the cell trying to deal with that problem. And then as time goes on, ultimately, the cell can't deal with the problem, and so that cell dies. And you reach a point eventually where, you've lost so many cells that now you have some sort of behavioral problem that is come about. So with respect to what should we do about that, I suppose, which is where your question was going, is I think there's two ways that you can gain information about it. Is one, if you can see these aggregates starting to accumulate really early, can you use that as a test to maybe start to say, as Veronica was discussing, some type of separation of different types of Parkinson's disease that might be presenting? Can we use that for more information to try to separate people and have more targeted therapeutic approaches? And then the other thing about it is there's been a lot of attempts to try to clear these aggregates. And then the question becomes, what are you clearing? Are you clearing the good protein that remains, the aggregate that was detrimental, or the Lewy body that might have been an attempt to protect? And so it really then becomes a really strategic approach to try to get to the exact peptide that was causing the problem and leave the positive aspects alone, which is challenging.
Thank you. Well, we're getting close to start diving into treatment, but before doing that, I really would like now take the opportunity to take questions from the audience about the diagnostic process or mechanisms that you may be interested in.
Given that there's no cure for the detection of Parkinson's or the prevention of Parkinson's, what are the benefits of early diagnosis?
That's a great question. Okay, well, do you want to
Take it.
You can take it, Justina.
Yeah. I actually think it's a really interesting and philosophical question, because right now we are, I mean, not our clinic specifically, but programs across the world are following patients that have REM sleep behavior disorder. And you know with those patients that there's actually a high rate of phenoconversion to Parkinson's disease. And if any of you wanted to know a few years before now that you would develop Parkinson's disease, would you? If you did not, if we do not have a cure. So it's an interesting question. But one potential benefit is that we may be able to apply clinical trials at actually that stage of the disease, knowing at what rate patients phenoconvert to Parkinson's disease to see if we can actually slow the progression. So I think that would be the most important aspect. From a personal view, I think probably, I would guess, most of you would choose not to know a few years before if you stood a high chance of developing Parkinson's.
Yeah, I just wanted to add to this. But this is exactly the point. You will hear about a lot of clinical trials. There are a lot of clinical trials happening in Parkinson's, but they are testing interventions that are doing different things to Parkinson's. Some are primarily alleviating problems that already exist and that already have formed, and the idea is to optimize functioning and reduce some symptoms when they have already manifested themselves. But there is a group of interventions that are being tested which really would like to get to the core of the basic mechanisms of Parkinson's, and these are the ones that we need early, exactly the group of individuals that Dr. Sarna was referring to, who are at a very early stage, because the so-called disease modification intervention would really be effective more at that very early stage. So clinical trials have different scopes, all very noble, but when we talk about disease modification, we mostly talk about as early as possible in the course of the condition. Thank you.
Thank you. Is it on? Yep. Oh, okay. Sorry. I just didn't think you could hear me. I'm personally confused as regards depression. I don't know if depression can be defined as a symptom. To me, it's a result. It's essentially the action your brain cannot handle the situation you're in. So if what I'm saying is right, then depression is more like a result. If I can't move when I was moving before, and I'm trembling when I wasn't trembling, let's say 2 days ago, and you ask me to come along and go walking with you, I'll be going, I don't want to be shaking, so I don't want to go. So I will actually act in a different way, and you may think that I'm depressed, because I am depressed. I hate the fact that I can't move now when I was moving before. So I don't know, correct me if I'm wrong. To me, depression is just a result of, you can't use symptoms, or I wouldn't use depression as a diagnosis of me having Parkinson's.
That's
Sorry.
That's
Sorry.
to you, Dr. Brewer.
Yeah, sure. Because that's extremely important. I love the question and the reasoning behind it. It's perfect, so it makes a lot of sense. The truth is that what you're mentioning are normal emotions reactive to something that is, as you mentioned, not easy to face. So my body's changing, is not behaving as I'm expecting. I was planning a retirement that is not happening because all these symptoms, things at home have changed a lot. What I expected to be my life is not that life anymore. Frustration is one of those emotions. Sadness is another completely natural, normal emotion. Like grief is a normal emotion because there are a lot of losses associated with those changes in the body and the family and in everything else. But depression remains, the word depression, we still use it as a clinical syndrome. With that, what I mean is a combination of some of those emotions, but they exceed that reaction to what's going on and they become constant and sometimes not really associated. Let's say you are taking your meds and you're doing much better, but you're still very down, and things that you used to enjoy and love you're not enjoying anymore, and you lose your appetite. So we combine different manifestations to diagnose depression. So it's not just that anger or that sadness or that grief that comes when something changes dramatically in your body and your life, but it's a mix of those things that when we put together, we know they are taking us in a different direction. All of those need to be addressed, because if it's just anger or frustrations, we need to talk about that to see how we can make it better. But if it's depression, we know that that can progress and become severe, and it be sometimes the main determinant of your quality of life. So we really need to target an intervention to manage that. So that's the difference. In the past, people used to say reactive depression or non-reactive depression. So if there was something triggering it, it would be reactive. But in Parkinson's, we know, those emotions are part of it. But when it becomes constant and kind of dissociated from the rest of the symptoms is when we start observing, and we may put a diagnosis of depression and treat it differently. Does it make sense?
Thank you.
Hello, thank you for the panel. I appreciate it. Dr. Martino, you mentioned the potential tools that you have that it could characterize some of the subtypes of Parkinson's. Like one of my biggest frustrations is not really knowing if I have Parkinson's. I keep asking myself, do I actually have? I know I have a lot of the symptoms, and I express a lot of the problems that come with it, but it's always in the back of my head. Maybe it's something more nefarious or something else that's affecting me. And hearing Dr. Ryan talk about alpha-synuclein and some of the factors that you could identify, you say that there's tools that can help you identify subtypes. Can those tools not be used to identify that you have Parkinson's in general? So, and I'd like to know more about these tools that you talk about. It's just identifying the synuclein, alpha-synuclein, or is there other things that are out there that we should know about?
Sure, I can speak a little bit more about alpha-synuclein and testing it as a tool. So these tools are very new, and I would say they are not widely in practice yet. But the basic idea about them right now is using the presence and absence of alpha-synuclein, or the aggregates of alpha-synuclein specifically, to be able to say, you have Parkinson's, you don't. Right now, the tool is not developed enough to be able to separate people into subtypes and to be able to say you have primarily a movement-associated disorder without any depression or non-motor symptoms. That tool's not there yet. But one of the things we're doing is trying to bring it there. So maybe there is something about that aggregate structurally that we can see, that we can use to get more information about what has happened in that specific individual, and looking at how it's changing over time. Is it spreading from the central nervous system into the blood? And maybe there are more things that we can look at that can give more information to allow us to start to look at people in a more, a precision approach or something tailored to each individual, as opposed to, what we have now, which is really quite binary. And so I would say they're in development, and we're trying, but right now that test, even though the test per se is really new, is just designed to be able to say presence or absence.
I have a question or a comment, I guess, discussion that's kind of off the exact topic of what we're talking about, but what are you doing to push this kind of information diagnosis down to the GPs and the professionals that deal with mental health? I know for my example, I've struggling for several years with something was not right cognitively for me, and I couldn't figure it out. And finally, I went for dementia testing and then we happened to get lucky and tripped over a good neuroscientist, a psychologist that identified the PD. So, but I found, I'm not sure the general frontline medical people are aware of, because these symptoms are so intangible and so soft and subtle until you figure out what track you're on.
Yeah,
Dr. Carney?
I'm happy to take that. I think that's a really, really important question, because oftentimes the neurologist is not the first point of contact, right? It's your family physician or other primary care provider. And so that is fundamental to getting an early diagnosis. Is when you go see that care provider, they will know what's going on. And so, lots of different ways that we're trying to provide education to our colleagues. It starts in medical school, right? So there's been a completely revamped medical school curriculum here at the University of Calgary starting this year, which has been going really, really well, helping medical students approach problems differently. As those students go on into residency, whether it's, you mentioned, family medicine residency, neurology residency, psychiatry residency. The family medicine residents do rotate through the movement disorders clinics with us, as do psychiatry residents. And then beyond that, us as a group, we're growing. We're providing continuous medical education to our colleagues in the community on an ongoing basis. But most importantly, events like this to educate people like you, so you can be well informed when you go talk to your primary care provider about your symptoms and what you're experiencing, which would then trigger an early referral to see one of us. So it happens in multiple stages at multiple levels of training. Certainly, as you can imagine, there's a lot for a family physician to know. They have probably the hardest job in healthcare, in my opinion. But we do try and make an effort to start at the medical school level, where we all teach through residency and then ongoing in practice as well.
That's great. There's a question there, and then over there.
I was wondering whether there's anything being found out about Parkinson's originating in the gut.
Who wants to take this?
I can take it.
You do.
Veronica?
Yeah, no, it's you're making all the best questions. That's a lot coming in regarding the connection between the gut and the brain, and you probably heard a lot because it became very public And you also probably feel it, when you are constipated, the pills don't work well, and there is clearly a relationship there that we kind of neglected for many years, and now we're all focusing on, because for sure this is something important. So a few years ago, we thought we had it all clear, and there was this publication saying some Parkinson's starts in the brain, some Parkinson's starts in the guts, and that can help us divide the subtypes. And it was very popular for some time. Then it started to lose its strength, because unfortunately nothing is easy and perfect with this disease. It's so complex that it always finds the way around to make it more complicated. But we know some facts. For instance, we know that alpha-synuclein is also accumulated in cells, in the neurons that manage the bowel movements, like around our mouth, in what we call the autonomic cells. We know that if we take a sample, we can sometimes measure alpha-synuclein in those cells. We know that constipation is one of the very, very early symptoms of the disease, sometimes preceding it again, 20, 15, 10 years. And when we ask patients that, well, I was constipated all my life, I said, well, it was because of this. We also know that the bacteria that live in the bowels of all of us, that's called the microbiome, are different in people with Parkinson's and in people without Parkinson's. And we don't know if that's the egg or the chicken. We don't know if that happened before the Parkinson's or happened after as a consequence of the constipation and the medications and the diet changes. But we know that we can really look at bowels and detect which type of bacteria are more common in Parkinson's. We know also that medications like levodopa can be taken by some bacteria and degraded before they even reach your bloodstream. So some people may think, oh, I take the pills, but they don't do much, and they may just end up being destroyed in your gut before you get to absorb them. So we know the connection is huge. We don't know exactly what comes first again, but there's a lot of research going on about it. So we have studies here running to try to understand the microbiome of Parkinson's a bit better. Different microbiomes may predispose to different non-motor symptoms, to different responses to medication, to different motor symptoms. So there's a lot going on. And some practical things come out of it. For instance, we know that treating constipation also improves medication absorption, motor fluctuations, dyskinesia, because if your pills can make it to the bowels and get absorbed well, you will get more of the benefit. We also know that, for instance, probiotics, and I am sure you read about it, may help a lot, not just the constipation, but also the ups and downs that you may experience during the day when you take your pills, and even the rest of the non-motor symptoms. So that study came out recently, and it's about one specific probiotic, but in general, we recommend them because they seem to work. So there's a lot of connection. It's a very important topic. The final word is not out there, but I know that I trust, my hope is that we will get very important information about Parkinson's itself just looking into the gut.
And check the poster on the SMILE study on the back as well. We have one more question, after which we will dive into therapy, but there will be more time to actually discuss after the panel discussion.
So thank you. I hope this is a quick question. Dr. Ryan, you spoke about different causes like genetic and pesticides, etc. Is there any link between Parkinson's and chronic psychological stress as a cause at all?
I'm not sure I'm the right person to answer that, actually. Chronic psychological stress and Parkinson's onset, so preceding Parkinson's. Yeah, I would say if from a mechanistic standpoint, when you look at things that are going wrong inside neurons, there's always overlap. So if you look at neurodegenerative diseases, there is, because my area is the cell biology of the neuron, so there's always a problem with transport. There's always a problem with protein folding. there's always a problem with clearing the aggregates, and these things come together and culminate. And if I think of other psychological disorders like schizophrenia, there's similar neurobiology problems. But with respect to if one precedes the other, I think I would turn that over to some of my colleagues perhaps to comment.
There was a famous footballer from the Liverpool Football Club whose one of the first symptoms of his Parkinson's was actually emotional and physical stress, and he was completely drained after his games, and that also led to emotional stress as well. But this is an area that it's being investigated to some extent. Well, even some of us here in Calgary are also looking at stress mechanisms and Parkinson's at a cellular level, but there isn't any clear definitive answer. But it is a question. It is an important question.
I guess we can bring, there was a question about ADHD and Parkinson's, so we can bring it quickly because it may be related.
There was a question about whether there's an association between ADHD and Parkinson's. This may seem a complex question given that ADHD is a neurodevelopmental issue, and whereas Parkinson's happens later in life. But
yes, just briefly, because it's a very smart question. Because if you have a kid or someone that has been diagnosed with ADHD, you probably heard that there is a dopaminergic deficit, and then you said, okay, but I have Parkinson's and I have a dopaminergic deficit, so what is it all about? The truth is that there are what we call associations, but we don't know the strength of those associations. So there may be a correlation. The dopaminergic deficit is in different areas of the brain. And when we look at a lot of people that had ADHD may have an increased risk of developing Parkinson's. However, it's not a straight line. So we are in a very kind of early area to discuss further about it. We have here in our team researchers that are looking into that association of ADHD with neurodegenerative disorders. Some things look more promising the doors in terms of finding, if there is a common mechanisms, but it's not, again, it's very early in terms of the exploration because ADHD has not been really investigated too much until very recently. So I would not, have any concern. I have Parkinson's, my kids have ADHD. Does that mean they will have Parkinson's? Because that's not the way we think it works in general.
Okay. I would like to now start talking a bit more about treatment, and starting from the novelty. One of the novelties of the year is that hopefully in the first few months of 2024, Canada will have approved a new formulation of levodopa, carbidopa, which is an infusion delivered under the skin, subcutaneous pump, and we're fortunate here in Calgary having Dr. Sarna, who has worked on the trial that has led to the approval of the product of the pharmaceutical compound, but whereas we are in the final stages of the pump approval, and then there will be some negotiation around the reimbursement plans for each province. That will take a little bit of time too, but I guess the first question is that, and I'm reading from what we have, is that do you know what the criteria will be to use this medication, and if there is any, what the protocol will be for someone already on duodopa, which is clarification that I think it's useful.
So I agree. I think it's very exciting that we will have this new medication available to our Parkinson's patients. And we're also very fortunate that we already have some experience with the product through the clinical trial. At this point, we expect for it to be available in the next few months, but we don't have the final date. And we also do not know what the criteria will be for patients to be able to be eligible for the product. That's to be determined. I suspect that the criteria in terms of how much off time patients have to have will be similar to levodopa carbidopa intestinal gel, which is the duodopa product, but I don't know that for certain. And then in terms of the duodopa patients that we follow, I expect that we will offer them the opportunity to be able to transition to this new medication while we leave the PEG tube in place to make sure that the new product works just as well or potentially better. It is going to be a 24-hour infusion. Currently, most of our patients on duodopa are 16 hours with oral medications overnight. But I think for a lot of patients that have difficulties optimizing their medication schedule and their on time, their good on time, this will be an excellent option for many of you.
A related question to this is an interesting one, is that someone asked whether the continuous infusion of levodopa, and I guess this applies to both of the intrajejunal, the intestinal one, and the subcutaneous, does this delivery system per se have some neuroprotective role?
I don't think at this point we have any evidence to suggest that it's disease modifying, meaning neuroprotective, so I would not expect for it to basically modify the disease course, but in controlling the symptoms better, obviously patients will do much better.
That was a necessary clarification, I think. And if I still can take advantage of having you next to me, there was a question about if there's a relationship between long-term use of levodopa carbidopa and heart issues.
Yes, this is something that has been in the news some time ago, but studies since that time have really disproven that. We know that when you follow patients prospectively that are on levodopa treatment, there's really no indication that risk of cardiovascular disease, ischemic heart disease are higher.
Right. Okay. We'll have the chance to come back to the pump in a short while. I also wanted to go through a number of other questions that we received before the event. One of this is related to a medication that is used as a cold medication or to counteract common upper respiratory tract problems, which is Ambroxol, which is currently in a phase 3 trial in the UK as a disease modification treatment, so to slow down the progression. So the question is whether similar products are being investigated here, but I guess also the question should be, what is the prospect, I guess, about Ambroxol and similar products? Dr. Karnik?
Yeah, so maybe I can give a bit of context around Ambroxol. So drug development and clinical trials, understandably, as the cost of everything is increasing, can be quite expensive, and a big portion of that is developing a new medication. And so the use of Ambroxol is kind of using this methodology of, hey, we've developed so many medications over the years, maybe that some of these older medications that we have or that are used for other purposes can be repurposed in a way to treat a condition like Parkinson's disease. And so like Dr. Martino was saying, Ambroxol is a cough suppressant medication that's used in the UK, and someone hypothesized that there may be potential disease-modifying effects in Parkinson's disease. And so how it theoretically works is that it could modulate a protein called glucocerebrosidase, or GBA. And you might have heard of that because people with mutations in the GBA gene have a higher chance of developing Parkinson's disease. And so how it works is it modulates that protein. It increases the level of the GBA protein, which then modulates alpha-synuclein activity. So it helps get rid of the aggregates, and we actually see increases in free alpha-synuclein levels in the CSF, the cerebrospinal fluid that surrounds our brain and spinal cord, when people are given Ambroxol. And so the phase 1 and 2 study that was done showed safety of this product, and it showed that we saw increases in this GBA protein And we saw increases in the free alpha-synuclein in the CSF, meaning that those aggregates are probably being cleared, but we don't know that for sure. And that's why this phase 3 trial is being taken on, which is going to follow patients for longer to see whether the symptoms of Parkinson's disease slow down, and we do see disease modification. So this trial is ongoing at, I think, 12, or starting up in 12 sites in the UK. We are not investigating that product here. And there's a variety of reasons why products get investigated in different parts of the world. Some of them are financial. Some of them are the company that owns the product has a geographic restriction. Some of it has to do with government regulation. So we are not investigating that product specifically here in Calgary. But we are involved in many clinical trials here, some of which are still recruiting or just completing recruitment, and some which will be starting up soon. And as our team grows, we have the capacity to take on more and more of these clinical trials, and we're really excited to do so. But it's really cool seeing studies like this Ambroxol study being done in the UK as potential disease-modifying agent.
Thank you. Thank you for the rundown. Changing a little bit topic from Ambroxol and GBA and to the question about the possibilities of a vaccine for Parkinson's. Dr. Ryan.
Yeah, so I've read about a phase 1 trial for a vaccine against synuclein, and the idea being that you would target synuclein aggregates so the immune system would clear it. And it's a really exciting idea. I think it's really cool, and I don't think it has progressed into past phase 1, past safety. But I think also when you get excited about something like that, you also kind of have to put it into context about what exactly kind of is happening. So even though I think it's an exciting idea, when I talked about that continuum of, synuclein that's being lost, then you have the aggregates, you're really just targeting one piece, right? So when you think of a vaccine, you might think, I'm protected and this won't happen to me. Where I think, you have to put it into the specific context of what it's doing. And then it also kind of works from the principle that synuclein is what went wrong. And I think that's probably also an oversimplification. There's a lot of metabolic problems with mitochondria that produce energy that also kind of are happening in people who have certain subtypes of Parkinson's. So I think it's an exciting area. I think it's kind of a new developing area of targeting these different types of aggregates with antibodies. But I also think it's probably only going to sort of reduce severity and progression. I don't think it's going to be a protection necessarily.
I agree with that. Moving now to targeting specific aspects of the condition, and there was one question related to gait problems, and indeed, I mean, we know that gait difficulties are a tough enemy in the sense that they don't typically respond to dopaminergic replacement strategies like levodopa or agonists, most likely because they don't depend specifically or certainly exclusively from the dopaminergic system, but from other systems too. So there's a question about a technology in Europe to target freezing of gait, and it refers to a mixed augmented reality version undergoing prototyping, which offers more sophisticated optical cueing and audio cueing directives, enabling the patient to seamlessly navigate confined spaces, corners, and doorways without freezing. Because freezing of gait in Parkinson's may have a number of triggers, including going through doorways or similar narrower passages. And some users report improvements up to 6 hours after headset removal, which indicates that there is a learning process related to this augmented reality strategy to treat this specific gait problem. Is it something that the movement disorders clinic could evaluate and further refine through other augmented reality expertise on campus? Anyone wants to express an opinion on this particular approach? This is a question that we have to, or at least it's an area that we have to comment on for sure, because it's a commonly recurring problem for patients.
I can comment briefly about it. Freezing of gait is a very, very disabling symptom. And like Dr. Martino said, really for most patients, it's not something that is responsive to medication. And a lot of patients will sometimes on their own learn that there's a lot of cues that will help their symptoms. And really this idea, which I'm glad someone asked about because it made me look into it and look at videos. It's very interesting technology, but currently there are much simpler technologies that patients use, such as, for example, walkers that have a laser beam. Some patients may even get creative about placing lines as a cue to reduce the freezing. But this really requires basically wearing of a headset that is actually providing those kinds of cues. And I guess the most interesting aspect is the fact that there may be some residual effect even after the headset is removed. So I hope that this is the kind of studies that we can participate. We actually do have a local expert in freezing of gait here in Calgary, Dr. Hugh. And I think this and other technologies actually hold a lot of promise for a problem in Parkinson's disease that really may require a lot of creative strategies.
Any other comment or?
Yeah, I mean, I think it's a fascinating thing, right? Because it's definitely a different network in the brain that's involved in the usual tremor, stiffness, and slowness of movement. And it looks like a variety of different sensory things can help, right? So sometimes it's touch, sometimes it's sight, sometimes it's sound. And I think this is a really cool avenue of research, as Dr. Steiner was saying.
And definitely it's an area that the University of Calgary and CaPRI team is looking at from many different angles. I mean, we have the cueing approach from Dr. Yu, mostly related to auditory and musical cueing. We have spinal cord stimulation that is a feasible reality here in the research context in Calgary, and there is certainly very nice advances about spinal cord stimulation around the world, as well as a mechanism to help locomotion in people with Parkinson's. We have basic researchers and surgeons like Dr. Whelan, Dr. Kish, looking at the role of other brain regions that could be exploited because preserved in Parkinson's as a way to enhance locomotion in people with Parkinson's. This is still being investigated at a preclinical level, but I am sure it will start being tested also as a new target for neuromodulation also in patients. And so this is bringing us to the neuromodulation piece. And there's an important question, which is always nice to remind even an educated audience like ours today about who is the ideal candidate for deep brain stimulation in Parkinson's. Dr. Carney.
Yeah, so this is a really good question because I think it kind of goes back to what we were talking about with the intestinal gel and the subcutaneous infusion, which is how do we get symptoms well controlled in a consistent manner. And the challenge with taking levodopa-carbidopa immediate release pills is that when you take them, the levels spike and then obviously they wear off, and then they spike when you take your next dose and then they wear off. Which is fine in the early stages of the disease because you're in a nice window where you can handle those ups and downs. Unfortunately, as the disease progresses, that window does narrow, and then those ups and downs of the disease can become really, really challenging. And so this is why we have infusion therapies to try and keep administration of the medication nice and steady, and this is why we have a treatment like deep brain stimulation. And so I think the important thing to clarify off the hop is, again, deep brain stimulation is not a disease-modifying therapy. It's a symptomatic therapy, which consistently improves the symptoms of Parkinson's disease in a certain population. And so who's the ideal candidate for deep brain stimulation? Well, it would be someone with those ups and downs of motor symptoms. So in someone who takes a pill and then maybe an hour after their medication, they have those dyskinesias, those writhing, wiggling symptoms, and then those go away, and then 20, 30, 40 minutes before the next dose, the medication wears off, and people feel stiffness, slowness, tremor start to come back, and then it takes some time for that next dose to kick in. So those ups and downs with those motor symptoms are what we look for in someone who may be a DBS candidate. Usually, understandably, this is a pretty significant procedure which requires electrodes being inserted into the brain, and so it is a neurosurgical intervention. People like to try different medication options before we move to deep brain stimulation, whether it's adjuncts to levodopa or whether it's modifying the levodopa dose itself. But it's those motor symptoms that are the important ones to think about when we think about deep brain stimulation. So tremor, stiffness, and slowness. Those are the symptoms that respond really, really well to deep brain stimulation. Other symptoms, like cognitive symptoms or freezing of gait, which was mentioned, urinary symptoms, mood-related symptoms, tend to respond less well to deep brain stimulation than the motor symptoms do. So if there are fluctuating pattern to the motor symptoms, then someone would be considered a candidate. But there are other things that we need to take into account. So for example, if someone has significant cognitive concerns, that has a tendency to get worse after a deep brain stimulation surgery. If someone has significant anxiety or depression that's untreated, that can be something that gets worse after a deep brain stimulation surgery as well. I like to think of deep brain stimulation as basically continuous electrical medication, because basically it's just electrode that's active, that's providing consistent delivery of electricity into parts of the brain that respond to dopamine. And so if you have a symptom that responds well to levodopa, it's probably going to respond reasonably well to deep brain stimulation as well. So those are the factors we consider. It's a very, very thorough workup, as some of you may know. There's thorough neuropsychological testing done for any potential cognitive concerns. Neuroimaging is done. Meet with at least a few of our specialists and a neurosurgeon before we decide to proceed with a surgery like that. But yeah, I think if there are ups and downs in motor symptoms without these other cognitive concerns, mood-related concerns, which the mood concerns can be treated, then we would consider someone potentially a candidate for deep brain stimulation.
Thank you.
Yes, I just wanted to add some additional comments to the augmented reality. I've spoken to Dr. Krishnamurti and Dr. Mata, who are both using it for, firstly, autistic patients with some social disorders, and also for dementia patients in different social environments. And furthermore, I've had some feedback from a neurophysio at one of the general hospitals in the north of England that have been trialing this for about 6 months, and they have reported in some guided studies with 25 or so patients with different levels of Parkinson's disease. And they're reporting of, across the spectrum of these patients, some positive results, improvements in some standard characterization tools. This micro-Q technology has been developed by a company in the UK, and it's currently available in the US. It's still under trialing, but I think with the capabilities that the two computer science group professors mentioned on campus, there's a good opportunity to marry this and explore this avenue. Basically, the technology is based on the Microsoft HoloLens technology, and it is not that expensive in terms of a tool, a probe tool. So I'm encouraged in what I'm hearing and seeing by this development. Thank you.
Thank you very much. Yeah, I would definitely agree with this. I mean, virtual and augmented reality approaches to improve gait across the population, and not specifically for Parkinson's, is an area that has already produced tremendous outputs. And I completely agree that using virtual reality to develop new motor learning approaches, particularly it would be particularly useful in people with Parkinson's to overcome the problem of the dual tasking that they may face because of the difficulties in controlling and localizing attention. It is some loss of automatic motor behavior. What happens is that gradually with the condition there is a reduction in ability to sustain an automatic movement such as walking. So when we associate that to another task such as talking, or such as making a mental calculation, or simply emotional stress, some novelty in the environment that could be stressful, that could generate freezing, or in any case generates a cost in the gait performance. And virtual reality can help through training, through these programs, to deal with dual tasking and utilize compensatory mechanisms to improve performance, not only to minimize loss of function, but to actually even gain function with the passage of time. And in fact, we were also dreaming of coupling new non-invasive neuromodulation treatments like the low-intensity focused ultrasound that we can do today here in Calgary. We're starting to test in patients to these virtual reality or augmented reality strategies to help gait. This is something that we are keeping our focus of attention high on, but certainly there is an interest from whoever works on rehabilitation to work more and more on augmented reality, for sure. I think that we can open up for some more questions from the audience about treatment. Brian.
You talked about the pump. Down in the U.S., they have inhalers. Like when people are on off times, they can squirt an inhaler. Is that coming to Canada anytime soon?
I should say it's come and gone, but who wants to take the question?
Yeah, I can.
Okay.
I mean, so you mean the levodopa, the inhaled levodopa product? Is that right? Yeah. So there is a product called Imbrija, which is on the market in the U.S., which is being used as a rescue therapy for inconsistent off time or sudden off time for patients. I trained in the U.S., so we had the product available to us, and I have to say. It was a really nice idea, but unfortunately, when people were inhaling the product, it comes as a powder, which resulted in a lot of coughing and a lot of discomfort for patients. And so a lot of the product then got expelled when people were coughing, and so the effect wasn't as good as we had hoped when we were prescribing it. And so I don't know that I'm not sure that it's even going to come to Canada.
I was going to comment on the fact that we also had another product called apomorphine, which is a dopamine agonist, it's not levodopa, that entered the market in Canada and the US, for that matter, in two different formulations. One is a subcutaneous pen, like in a quick injection for rapidly active against sudden off episodes, and the other one was a sublingual film that was dissolved under the tongue. It came into market, we started prescribing it, and then it was withdrawn by both companies probably because apparently they didn't actually make what they were hoping to make from the market. Whereas there's always a time of adjustment, and doctors have to start familiarizing with the product, understand how to use it in the best possible way. So they were too rushed in taking it off the market, in my opinion, and there may have economic reasons for that. But none of us is happy about that. We were very frustrated because the time we spent meeting companies and patient advocacy groups to discuss these new options, which was not a major game changer, but it could have been very useful. It was a very long time, so we were frustrated.
But I guess if I could add to that as well, a lot of the rescue treatments are really designed to rescue in the moment when you go into the off state until your regular dose of levodopa is going to kick in. And so it's not that you get quick rescue and then you get a sustained response. And so ultimately, really with all of the rescue medications, that will continue to be an issue. And even with the sublingual film or the subcutaneous injection, it's really the same thing. You're still waiting for that levodopa dose to start working for you as you're trying to get the rescue from this one. Because they are quick on, but also fade away very quickly.
I just couldn't miss the chance of a political statement. Sorry. That's at least one. Questions? Yes. Thank you.
Thank you very much. This is great, actually. Very helpful. So I know you can't recommend any specific product, but there are so many probiotics on the market. I'm wondering if, Dr. Bruno, you could comment on just some general things to look for in a probiotic. They're not cheap.
I know. Yeah, I knew this was coming because I wrote a little comment and got lots of emails about that. And I'm sorry to disappoint, but I think we will have one specific probiotic soon. It's going very fast, the research in that aspect. However, right now, the best evidence that we have is for milk, kefir, or yogurt with probiotics. So that's what I recommend to my patients. We know that some patients may have an interaction between levodopa and protein, so don't take it together with the levodopa. But a little bit of kefir in the morning. If you are doing a lactose-free diet, you can use the kefir water that still has a lot of pre and probiotics, but not lactose or milk or like the little yogurts that come in these little bottles. We know those help. At the constipation level, we know the mechanism is similar to the studies that are showing that it also helps at changing the microbiome, but we don't have the final word yet. I would not buy, for sure I will not buy the most expensive one because that's never the best solution. I will, if you really don't like yogurt or you're lactose-free, you can search for these alternatives. Most of the generic formulations that we buy over the counter, we have no clue what they include. So I would go more for the natural way right now until they identify and tell us exactly the compound or the name of the ones we need to take. In the meantime, everyone that sells you something different is lying. So go for the natural options and then save that money for whenever the real one comes.
Are you referring to these single strain?
Yes.
I would endorse that. Our time's up, but we will have more chances to mingle and discuss more. I would like to thank my colleagues for having been with us today. Thank you very much, and thank you all for your great participation. Thank you so much.